Thank you very much, Gorka, for this excellent and very much comprehensive lesson and lecture about pitfalls of computed tomography. So now it's MR turn, and of course we are talking about a complex technique with partial overlapping, mostly related to the anatomical pitfalls we already heard about. My initial disclosure reported here is that this presentation has 64 videos, so this is already a pitfall we will hopefully manage to skip, but we worked with the staff, and so probably this won't be a problem. But the truth is that cardiac MR faces several important challenges that radiologists or cardiac imagers in general need to be aware of in order to avoid falling in pitfalls. And the first issue is related, and we're dealing with MR, to the complex cardiorespiratory motion shown in this real-time movie depicted here, which implies that there is a continuous upward and rightward motion of the diaphragm, and of course the heart is beating. What does it mean? That we have to develop and to use breath-hold sequences and to use ECG-gated acquisitions. And this is, of course, the first and basic step to perform cardiac MR. Or, of course, like in this case, there is also the possibility to use real-time techniques, which has quite limited use in current clinical daily routine. The second problem that we have to deal with, mostly as radiologists, is that the heart is not oriented according to coronal, sagittal, or axial plans within the chest. So we have to deal with plans that are usually non-familiar with, called short axis, four-chamber view, etc., but I won't focus on that. Third problem, and we will extensively discuss this point, is related to the presence of fat. Fat tissue completely surrounds the heart and is mostly visible at the level of the right ventricular free wall, as shown here. It is strictly connected with the epicardium, so when we will discuss about possible depiction of fat infiltration and arrhythmogenic right ventricular dysplasia, we will show how much this can be tricky and how do we overcome, if possible, this potential pitfall. We already heard about the anatomical pitfalls of the heart, and I will show you different cases. This is prominent crista terminalis I won't discuss, and you already heard about in the beautiful case showed by Gorka previously. There is a third point, which is MR-related, depending on the continuous turbulent flow, proton inflow within the cardiac cavity. So this causes turbulences, may cause artifacts that we may use to assess, for example, presence of stenosis with acceleration, like in this patient with a subvalvular aortic stenosis. You see that there is a dark rim artifact going into the direction of the systolic ejection murmur. And finally, and this is another point that probably represents the major pitfalls of cardiac MR, either for radiologists and for cardiologists, it certainly requires a long training curve because it is really a mixture of clinical and technical information to rely on. So I will try to review the most important pitfalls of cardiac MR, offering, whenever is possible, some practical solutions to overcome this limitation. And how did I organize my lecture is, as shown here, in anatomic pitfalls, technical pitfalls, and clinical pitfalls. And this is the pathway and the agenda I will try to discuss in the next 45 minutes with you. Anatomic pitfalls are the following, and possible the differentiation between masses versus pseudomasses, the problems of hypertrabeculation, which is a very common clinical problem, increased ventricular volumes, and the problem of fat. We will focus on the differentiation between real versus false perfusion defects. We will discuss about late enhancement, when is it true, when is it false, and how do we approach the problem of late enhancement, and we will discuss some clinical cases with related possible important pitfalls. Starting with anatomic pitfalls, how will I manage with them in my lecture? I will show you the clinical problem to solve, so a kind of simulation of the clinical request we do receive. We will discuss one or two cases related to that clinical request, and hopefully I will manage to offer some pearls, as the title of the lecture meant to do. So, the first group of clinical requests we are very often addressed to is evaluation of cardiac mass. So we receive, in this case, the clinical history of a 67-year-old man who was admitted to the emergency room with dyspnea and syncope. At physical examination, he had a 46th systolic ejection murmur over the pericardium. Transthoracic echo, that I'm not showing to you, showed a large intracavitary mass obstructing the right ventricular outflow tract. And of course, this is a first-class indication. Cardiac MR was required to further characterize the lesion. And we published this case some years ago with my colleague from Greece, Maria Calanzi. And the first line here shows black blood ECG-gated sequences, T1-weighted turbospin echo. I will just comment the findings without specifying my interpretation, of course. There is a rounded lesion here, located at the level of the right ventricle outflow tract, and this explains clearly the symptoms and the acute onset of the disease in this patient. Behind here, you have the steady-state free precession sequences. What I ask you looking at this case is to carefully review the anatomic location of this lesion. So, my first question, what is your diagnosis? Is it a cardiac thrombus? Is it a primary obstructing neoplasia of the right ventricular outflow tract? Is it an aneurysm, or is it a diverticulum of the pericardium? Oops, sorry. Wrong mistake. Yep. Again, look at the location. Okay. Most of you mentioned the answer C, which is the correct one. It is an aneurysm of the Valsalva sinus. I will show you the cine because I wanted to be bad and to make the case more difficult. This probably makes things clearer. And the first movie is not working here, but it's clearly already that you have a lesion which is communicating with the lumen of the aorta, and it is an aneurysmatic Valsalva sinus which is protruding within the lumen of the vessel. This is a typical case of a pseudomass which was clearly interpreted as a tumor, and, but I will show you how much things cannot be straightforward. Another case, also from our experience, same clinical history, we saw very close to the previous one, is a 33-year-old male. So clinical acute onset of disease, dyspnea and whatsoever. This is not a clinical case I'm showing you, but you see a lesion again located within the right ventricular outflow tract. Different from previously, I didn't show you the T2 images. We have a high signal intensity, and it seems that there is no communication with the aorta. And this is a myxoid leiomyosarcoma, so things are not always straightforward. Look at the signal, because myxoid component in T2 has a high signal intensity. Look at the cine, how we did before, because when you see the flow of protons within the ascending aorta, you will immediately realize that there is a communication. So the right sinus of Valsalva's aneurysm are not that rare, mostly because it's a frequent clinical request to cardiac MR. They are congenital or acquired from deriving from localized weakness of the elastic lamina and or an underlying deficiency of the normal elastic tissue. Which are the CMR criteria? We already discussed about it. Origin above the aortic annulus, secular shape, and normal dimension of the adjacent aortic root. So it is crucial to make a prompt and accurate diagnosis when we have cases like that, because patient needs to be urgently addressed to surgery, and this is what happened to the first case I show you. Still, we are in the field of anatomic pitfalls, masses versus pseudomasses. This guy here was a colleague, of course, so as already Gorka mentioned, whenever we are dealing with colleagues and whatsoever, either we had bad exams, either we have strange cases, and this was the case. He was a heavy smoker, 68-year-old male, cardiological screening which was done for dyspnea and cough. He did a transthoracic echo, which is shown here, showing this lesion protruding in a parasternal view within the lumen of the right atrium, pedunculated. Of course, a further exam was required. The first thing we did, because of organizational reasons, was a CT of the chest. So notice that there is a nodule located within the inferior, the superior left lobe of the lung, which has characteristic of benign behavior, regular shape, and you see the lesion here, which is involving the interatrial septum and the posterior wall of the right atrium. So, of course, when you hear such a story, I didn't see the images. I turned to a pessimistic interpretation. I was called by the colleague. He said, okay, I did this. These were the findings. My first diagnosis was, you probably have an angiosarcoma, just because I'm an optimistic person. And we did MR, which is shown here. So CNS steady state free precession. Again, look at the signal of the lesion, T1 weighted turbospin echo, and fat suppressed sequence. 4-chamber view for all the images. So what's your diagnosis? Is it a myxoma, typical location? Is it an angiosarcoma? Was I right to be pessimistic? Is it a thrombus? Is it a cardiac metastasis? Is it a lipoma or lipomatous hypertrophy of the right atrium? Please vote. And I will go back to the images so you have better opportunity to check. Results. Okay. Most of you are right, and it is a lipomatous hypertrophy of the right atrium. What is the hint, the clue to look at this image, of course, is that there is a high signal intensity lesion which completely suppresses, and it is the location. So another case, not from our experience, but it was published, very similar to the previous one. So whenever you have fat tissue involving the right atrium, it is homogeneously suppressed. It's part of the congenital development of the heart, and we may have local accumulation of fat within that location. It's another very typical pseudomass, 1 to 8% of incidence. It is associated with increasing age and body mass, asymptomatic in most cases. Of course, it might be a source of supraventricular arrhythmias. At histology, and this is a differential diagnosis versus a lipoma, it is a non-encapsulated mass of adipocytes interspersed within the atypical and hypertrophied myocyte. Whenever we do an MR for those cases, do not ask for biopsy and even do not ask for follow-up because it's very typical. Again, just because I want to scare you and to show you how much cardiac MR and cardiac imaging may be complicated, this is a case we published some years ago on the Italian Journal of Radiology. On the left, you have a lipomatous hypertrophy, which had the similar characteristic I showed you. On the right, we have a primary cardiac lymphoma, which was part of a wider diffusion of disease. The differences are related to the strong enhancement of the lesion. So again, also use an integrator images with contrast administration. So first pearl, hopefully useful for you for daily clinical practice. Whenever you have a request for a cardiac mass, you have to realize and to ask yourself whether is it a pseudo or a real mass. Pseudo masses are common anatomic pitfalls. We saw the case of the prominent crista terminalis before. There is a prominent Chiari network or Eustachian valve, which has almost the same location, or an hypertrophic moderator band, which is in the right ventricle, may mimic a pseudo mass. One case, it's a crista terminalis here. On the other hand, pseudomasses are also non-tumoral lesions, so we do consider aneurysm, hiatal hernia, another typical example of tumors that are not, abscesses, thrombi, etc., etc. And this was the first issue I wanted to discuss with you. Coming again in the field of anatomic pitfalls to a very common clinical request, again addressed to our attention. A colleague is doing echocardiography, he sees hypertrabeculation, he wants MR to give the solution to the problem. So how to deal with the problem of hypertrabeculation? Let me explain and show with you and discuss with you the embryogenesis of the process of compaction, which is characterized by an initial looping of the endocardial layers, which progressively causes formation of trabeculae, as shown here. And with the development from the 6th to the 9th month during embryonal life, those trabeculae close and there is a compaction process within the ventricle. You can imagine how much this process is a continuum from the complete trabeculated towards the compaction of the ventricle, and this is what we are dealing with, and the limit between normal and pathological is not always that straight. So 3 patients, actually it's not fully true, same clinical request, but we had a report on the echocardiography claiming that there was a suspected hypertrabeculation, and so to rule out left ventricular non-compaction. So look at patient number 1, patient number 2, and patient number 3. These are all 4-chamber view CNA steady-state free precession images. The patterns are completely different if we do consider ejection fraction. First of all, number 1 and number 3, of course, have a severely compromised ejection fraction. Patient number 2 has a well-preserved ejection fraction. So, are we able to answer to the request according to these images? Are those 3 cases of non-compaction? How to deal with these cases? So, what's your diagnosis? Number 1, all cases of left ventricular non-compaction, according to the criteria I will discuss with you in the next slides. Is it overall a normally hypertrabecular left ventricle for all cases? Or all patients have different stages of dilated cardiomyopathy, and this is another diagnosis we have to think about. We need to quantify mass of the left ventricle. We need to measure the ratio of the non-compacted versus compacted myocardium and to look at late enhancements. How would you deal with such a clinical presentation? And again, let me get back to the cases so you can review what we are talking about. Okay, probably this was too easy. Of course, we have to look at late enhancement and to measure the compacted versus non-compacted ratio. Number 1 here has a clear left ventricular non-compaction. We measured, and I will show you how it deals, the ratio between non-compacted versus compacted fibers, and it was higher than 2.3, which is positive according to one of the 2 proposed criteria. So the first approach to measure and to give the diagnosis of non-compaction, which is still, in my opinion, a huge confusion because we don't know exactly how to deal with those clinical information. But what was suggested by Dr. Pedersen a few years ago in 2005 is to measure from end diastolic images the the non-compacted component of the left ventricle, and whenever the ratio was higher than 2.3, there was a cutoff and the sensitivity of 86 and 99% for the diagnosis of non-compaction. What came out after this initial paper is that a large number of patients, up to 43% of patients, could result positive according to those criteria. So the risk using the previous criteria is that we have a large population of patients with normal myocardial fibers, just with a pronounced non-compacted amount of fibers, which we call non-compaction, resembling congenital heart disease with the risk of development to heart failure and transplantation. So what was further done by Alexis Jacquier from France in 2010, he proposed a new criteria, which is probably more sensitive and more specific according to literature. He proposed to measure, as shown here, the trabecular mass and to make a ratio between the left ventricular mass versus the trabecular mass, and if their amount was higher than 20%, the specificity and sensitivity raised to 93%. So these second criteria are more widely adopted to make a diagnosis of non-compaction. But what's the problem? Again, patient number 2 is a professional football player. He just had a hypertrabeculated myocardium, perfectly preserved normal function. So in this case, really no further imaging. Diagnostic pathway should be concluded. It is usually addressed to MR because of probably less experience of the echocardiographer, but no further imaging, and I would say not even contrast agent should be administered in this case. So, by the way, this player is Francesco Totti, 20 years with a single team, so let me dedicate 30 seconds to that, because we are talking about hypertrabeculation in the left ventricle in athletes, which is very, very common. So, again, if we look at the criteria I previously showed you, and we look at the hypertrophied ventricle of the athletes, up to 8% of the athletes should fill conventional criteria for non-compaction. So, I think you're probably getting confused, but this is what we do have also in our experience, because it's an entity not clearly defined. It's a continuum from normal to pathological, and we have to carefully deal when we are calling a pathology non-compaction versus compaction. So, of course, in the athletes, consider the history, LV function, and ECG. And the last case here is a 30-year-old male with known coronary artery disease. Ejection fraction in this case is around 10%, so severely compromised. The ratio is 1.8. This patient has a dilated cardiomyopathy. The overlap between dilated cardiomyopathy and left ventricular non-compaction is extremely high. We'll have to look at late enhancement to pose a differential diagnosis, which is not always possible. And of course, you see in this patient there is no sign of late enhancement within both ventricles. The ventricle is severely dilated, severely dysfunctional, but probably viable. And again, several papers in literature focus on this aspect, but the truth is that it's not really easy to differentiate dilated cardiomyopathies versus non-compaction. One ratio is related again to the amount of non-compacted fibers. So how to approach to hypertrabeculated ventricles? First of all, as I mentioned, it is a continuum spectrum from normal to pathological hypertrabeculation. It's a very common CMR request. We have always to consider differential diagnosis, so dilated cardiomyopathy, ARVC, so arrhythmogenic right ventricular cardiomyopathy, athlete's heart, etc. Use the suggested quantitative cutoff. I always rely on the second one I proposed you, so to measure the mass of non-trabeculated ventricles, and also always consider clinical history and CMR ancillary findings, also, of course, late enhancement and whatsoever. So we are still in the field of anatomic pitfalls. We mentioned masses versus pseudomasses. We talked about the hypertrabeculated left or right ventricular modification. Probably this is a further very common request addressed to our attention. The typical history is a young guy who is doing an echocardiography because of screening, and you receive the request to further characterize an unexplained right ventricular volumetric increase. When is it normal? When do we have to worry about it? So the first clinical history is a 24-year-old male who had an enlarged right side of the heart noted in a chest, in this case, routine X-ray. He did transthoracic echo and transesophageal echo even, which revealed unexplained dilatation of the right ventricular cavity without any secondary causes. And incredibly, this was, well, let's say a procedural pitfall, the QPQS, which means the flows at the level of the systemic and pulmonary circulation, were not measured. So look at this, 4-chamber view. We have a problem with short axis, but it wouldn't have added too much. Right ventricle should usually be the transverse diameter slightly larger than the left ventricle, but in this case, you see we have 62 millimeters versus 46 millimeters. And let me show you the second aspect. We have an angio, so it means something. We measured with the velocity encoded cine the ratio between pulmonary versus systemic circulation. It was 1.8. At the level of the pulmonary flow, pulmonary artery, we had 123 milliliters. At the level of the aorta, we had 67 milliliters per second. So what do you think about? What's your diagnosis? Is it a patent foramen ovale? It is a patent ductus arteriosus. Does the patient have an intracardiac shunt? Is it a double vena cava? Or is it a partial anomalous venous return? And let me go back again. Probably this is slightly more difficult than the other cases, but it's not infrequent to find such cases in daily routine. So I wanted to introduce it as a pitfall and the risk of error. Okay, great. Most of you answered correctly. This patient has a partial anomalous venous return. I will show you more in detail. This is the venous branch which goes in the superior vena cava, the pulmonary venous branch, and is also depicted on the angio. I will stop the movie here. You see something is going on, and this causes an increased flow to the right heart and explains the right ventricular enlargement, which was completely missed. And I remember you that this guy was 24-year-old. So risk of right heart failure, dilatation, and developing of pulmonary hypertension was high. So just talking about pulmonary right ventricular enlargement, again, it's a common clinical request. Whenever right ventricle is enlarged, cardiologists are addressing the exam to our attention because MR should provide the diagnosis. It's the holy grail. You tell me what is going on, and probably it is true for a lot of things. Consider, of course, sport activity and whatsoever, so all the common causes of right ventricular enlargement, but there are also more rare and unrecognized secondary causes, which include intracardiac shunts, which should be depicted better with echocardiography than MR, anomalous venous return, PDA, embolism, and whatsoever. And our suggested protocol, whenever you have a right ventricular enlargement, apart from the usual CMR scan, you should add coronal or axial turbospin echo or steady state true fist, whatever you call it, covering the whole chest cavity. Look at the chest, look at the great vessel, look at the possible presence of anomalous venous return. And of course, you should always measure the flow at the level of the pulmonary and of the systemic circulation, because it gives a lot of information. What's going out, it's going in. So if we have an imbalance between the ejection of the left ventricle and the ejection of the right ventricle, it means something is wrong. Another patient with, in this case, we knew that he had a pulmonary hypertension. It was depicted initially with CT, what we also did MR. You see an extremely large right ventricular cavity with some eccentric hypertrophy. Ejection fraction is reduced here, and there is a continuation between the pulmonary artery and the aorta, and this is a patent Botallo, published by my colleague Galea and Franco Iafrate in 2013. Still in the field of anatomical pitfalls, there is the problem of fat infiltration, another common request. As I mentioned at the beginning, in the first slide of my presentation, fat is everywhere in the heart, surrounding the heart, and it may mimic, is a sign of arrhythmic disease, but also in several other conditions we find the presence of fat. So I found this review paper very, very interesting. I suggest you to read it because it clarifies a lot about the correlation of fat infiltration within the heart and the spectrum of normal versus pathological condition we may deal with. As I mentioned before, fat is everywhere, and even histologically, the borderline between the epicardium and the epicardial fat tissue is quite difficult to discriminate. So you can imagine if we are looking at a criterion which suggests to depict fat infiltration within the left ventricle, how difficult might it be? So I show you two different cases. Again, 67-year-old man with dyspnea and atypical chest pain. He had no particular risk factors, but he had a history, and consider this anamnestic data, of heavy alcohol consumption, 5 beers per day, 5 liters per beer per day. It's even higher for our residents, so it's a record. Stress ECG was inconclusive for signs of infralateral ischemia, and it was addressed to CT to rule out coronary artery disease. Patient number 2 is a different story, 27-year-old patient with syncope during physical activity. He had T-wave inversion, so severe arrhythmias in the anterior and inferior leads. And at transthoracic echo, it was depicted a severely dilated right ventricle. So number 1 is a steady state reprocession. Number 2 is a double Dixon fat suppressed technique. You notice here, first of all, probably the second movie, I apologize, is a bit dark. Look at the dilatation or the regional wall motion of the right ventricle in both cases, patient 1 and patient 2. Look if you see anything from the screen in this patient. Look at both ventricles. I told you the first exam which was requested was CT, so I have to show you by contract the CT examination we did in advance, and which was followed by MR. So the unenhanced scan showed an hypodense band which arises from the epicardium towards the myocardium, as shown here, also on the arterial first pass images. We did a CT angio, which was substantially non-significant. So we did MR. We combined phase-sensitive inversion recovery sequences with T1-weighted turbospin echo, which confirmed this high signal intensity lesion within the same location, mimicking some late enhancement from short axis. What's your diagnosis? Is it a left ventricular arrhythmogenic cardiomyopathy? Is it a lipomatous metaplasia following myocardial infarction? Is it an alcohol-related LV fat infiltration? Could it be a lipoma, or is it a lipomatous dystrophy in an old patient? Consider that all these hypotheses are reliable and could be compatible with the appearance I just described. So we have fat subepicardially arising and infiltrating the left ventricle. Okay. The beer suggestion was great for you because most of you voted for the correct answer. This patient had an alcohol-related left ventricular fat infiltration. Let me proceed and trace my final conclusion about fat infiltration in the ventricle. It is not so much usual. It's an alcohol-related chronic inflammation, so it's a kind of myocarditis followed by lipomatous metaplasia, which occurs in a heavy drinker and causes a very typical metaplasia with fat infiltration of the left ventricle. Coming back to the second case, so the 27-year-old guy with syncope and major arrhythmias, this is the combination of T1 and T1 fat-suppressed sequences. You see a bright high signal intensity lesion surrounding the entire right ventricular free wall at the level of the mid-apical segments. Fat-suppressed sequences confirm that it might be fat. And again, the Dixon fat-water separation here shows an abnormal regional and global wall motion of the right ventricle, which appears enlarged. So this is probably much more easier. What's your diagnosis? We have another pattern of fat infiltration, which is associated with ventricular dilatation and enlargement. Is it an ARVC? Is it, again, a lipomatous metaplasia following infarction? Is it an alcohol-related fat infiltration? Is it a lipoma, or is it a lipomatous dystrophy? Again, look at the scene, which are quite clear. Most of you voted correctly for arrhythmogenic right ventricular cardiomyopathy. Why did I focus on those two cases? Because nowadays it's absolutely accepted and acceptable that fat is not anymore an issue of right ventricular cardiomyopathy. You have to look, and these are the important findings, at the volume of the left ventricle, the presence of aneurysm mostly located within the paraapical part, and this patient has an aneurysm, and of course at the regional wall motion. So if we rely on the revised criteria published in Circulation in 2006, fat is not considered neither a major, neither a minor criteria. So whenever you have a request for suspicious fat infiltration whatsoever, first of all, you have to consider that fat replacement occurs predominantly in the right ventricle, but is associated with a series of conditions. I showed you the alcohol-related because it's quite rare. It might be the expression of an healed myocardial infarction or healed myocarditis, tuberculous sclerosis also, lipomatous hypertrophy, and also in the elderly there is a fatty replacement of the left ventricle, which also have to be considered, and it is absolutely normal and physiological. Again, from the review I showed you, I have summarized and readapted this table showing the different location of fat in physiological, healed myocardial infarction, and arrhythmogenic right ventricular cardiomyopathy. And if you review these images, we have a lot of hints to differentiate both the three conditions. So we've finished this extensive anatomic pitfall part because I think it's part of what we mostly see, and focus on the technical pitfalls of cardiac MR, which are several. In this case, I would like to discuss with you two major points. First of all, the perfusion defects, and second, to focus on late enhancement. So, perfusion defects or artifacts. We have 3 patients, completely different stories. In all cases, our residents gave perfusion defects. Patient number 1, patient number 2, look at the lateral wall here, and patient number 3. No question in this case for patient number 1 because it's straightforward. You see that there is an inferior subendocardial perfusion defect persisting continuously after the contrast arrival. This actually was a lady, not a male, and she had acute chest pain, ST elevation, troponin raise. It was an acute myocardial infarction. We have scanned in our institution more than 200 patients with acute myocardial infarction. By the way, the exam is completely safe, so no risk related to stent implantation and so whatsoever. And it was associated with an RCA occlusion and with microvascular hemorrhagic obstruction with inferior location, like shown in this case. So this we call a true perfusion defect, which are the criteria recognized and described to discriminate between a real and a false perfusion defect. First of all, persists at least 3 heartbeats. It starts after contrast arrival. It usually spreads from the subendocardium to the subepicardium. We had a nice session 2 days in advance with the Rising Star program talking about myocardial infarction. And the very basic information is that the wavefront of necrosis starts from the subendocardium and spreads subepicardially. And of course, it is usually, when you are doing rest and stress, and I won't focus on that, usually more conspicuous during stress versus rest. So patient number 2 here, it's a dark cream artifact. We were, thinking, and we have daily cases like this of this tiny, subtle, hypointense area located within the lateral wall of the left ventricle, which is absolutely nothing. It was a suspected arrhythmogenic right ventricular cardiomyopathy, one of the 99.9% of negative cases that we see. Of course, this is not a perfusion defect. And the last case, female, 51-year-old, chest pain plus previous stenting of acute marginal branch. She had a known systemic disease. So look at this perfusion because a question will come related to this case. Look at first pass, look at distribution of hypointense rim, and look at late enhancement. My question, what's your diagnosis here? Is it a free vessel disease with diffuse myocardial staining? Since the patient had a history of coronary artery disease. Is it an artifact related to inhomogeneous distribution of contrast? Because there were patchy areas enhancing. It is a double anterior or inferior septal mid myocardial infarction. Is it a storage disease or is it an hypertrophic cardiomyopathy? And I go back to the movie just to let you think. Again, look at the distribution of enhancement at the location of the perfusion defect. Among the differential diagnosis, look at thickness of the myocardium, look at the distribution of the defect, whether is it ischemic or non-ischemic. I gave you 2 great suggestions. Okay. There is a fight between hypertrophic cardiomyopathy and storage disease. This was effectively, and I'll show you, a storage disease, was a cardiac amyloidosis. The differential diagnosis in this case is difficult as compared to the hypertrophic cardiomyopathy, and I will show you in the last part of my presentation, if I have time, also cases of hypertrophy. What happens in cardiac amyloidosis, which is the typical pattern, the typical observation we have. There is an hypoperfusion. So first of all, the perfusion defects are not ischemic. They are spread everywhere because amyloid accumulate within the intercellular space and it avoids distribution and diffusion of the gadolinium. So you see that very typical patchy appearance of the myocardium with patchy area of fibrosis. So there is late enhancement with perfusion defects. So the message here, of course, first pass is not always used and usable in ischemic heart disease, but should also be applied in storage disease. Coming to late enhancement, I won't focus on the late enhancement curve you probably well know and you probably heard about. What is important is, of course, to select the appropriate inversion time. If you look at this case, we have different inversion time in which we may find, we need to find an adequate homogeneous suppression of the signal of the myocardium. I would choose, which would you choose here? I would choose 280 milliseconds, because you see the lesion, the infarcted, like in this 51-year-old male with left infarction of the LAD, shows homogeneously high signal intensity, transmurally spread with some microvascular obstruction. So the problem is inversion time. We have to carefully focus on inversion time. Today, look-logger sequences exist, allowing to modulate inversion time and to select from a series of numbers. But look at this patient, 40-year-old male, again, suspected hypertrophic cardiomyopathy. These are the spectrum of inversion time applied. So my question, what is the correct inversion time? And I will briefly get back to the images so that you can think about 200, 250, 300, all correct or wrong, or we did a too late acquisition, for example, more than 25 minutes. What's your idea? Okay, the balance is between 250 and all correct wrong. Honestly speaking, if I had to judge an image with this inversion time, I wouldn't be happy. So probably there is something wrong. We didn't do a late acquisition in this patient, so there is something wrong related to the pathology of the patient. So I'm showing you two different phases of the same pathology. This is another case of amyloidosis in which the diagnosis with OVAR is straightforward, because the technicians or residents working on the machine usually ask, what's wrong with late enhancement? Since there is an infiltrative disease with diffuse deposition of amyloid within the interstitial space, late enhancement is always wrong, and you have this patchy or zebra pattern appearance that is described in literature. And I think I have another case, or sometimes this is an even better case, probably too easy, appears like this. The myocardium is inhomogeneous. We cannot suppress homogeneously the signal. So the pearl here in cardiac amyloidosis, when you have an hypertrophic patient, you don't find an adequate inversion time. Always think about systemic or primary amyloidosis, because the nulling inversion time is less than the one of the ventricular cavity, and usually wrong. Coming to clinical pitfalls, we have a couple of minutes, so I would like to show you probably this last case that we call the anxious lady, because she was really anxious, and came to our attention, a 47-year-old lady, initially, because probably in Italy we have this approach to the other gender, but the lady was described from all our colleagues as an anxious lady, so she will create problems. She had a history of light cigarette smoke, non-diabetic, hypertensive or dyslipidemic. She had a positive history for ischemical disease and was admitted with atypical chest pain. At admission, her echocardiography showed a normal ejection fraction, no increase of troponin. ECG showed aspecific abnormalities of left ventricular repolarization with some minimal pericardial effusion. So the final diagnosis at discharge was that this lady might have had an acute pericarditis. But the anxious lady came back after 10 days with persistent chest pain, dyspnea, and progressive fatigue. And she was addressed to MR because troponin raised with the suspicion of myocarditis. So look at these CNA images showing on short axis basal and mid segments, and on four-chamber view that the global motion of the left ventricle is almost preserved. There is probably something at the level of the lateral wall of the left ventricle here, which is hypokinetic. We did, of course, combined T2 steer and late enhancement acquisition, which shows something look at T2 on the first row, and look at late enhancement on the second row. I thought there was a question here, but there is no, there is later on there is a question. After MR, she did selective coronary angiography that I won't comment. Look at just if you see any epicardial stenosis or whatever. This is quite difficult. It's a bad question I'm asking you. The questions are, look at this. What's your diagnosis? And I'll immediately go back to the case of MR. Is it a chronic lateral with ventricular infarction? Is it an acute MI due to dissection of a coronary? Is it an acute myocarditis with focal LV involvement? Is it an acute MI due to circumflex hemodynamic stenosis? Or is it a pericarditis? Let me go back to the MR images. I remind you the story of this lady, poor troponin motion at the admission, chest pain, normal LV function, and she came back after 10 days with increased troponins and starting to have impaired or left ventricular function. The differential stands in the field of acute coronary syndromes. Okay, there is a discussion about acute myocarditis versus dissection of the coronary. Let me go through the case again. It is a spontaneous marginal branch dissection. If you look at this image, there is a line here that spontaneously arose. So patient had an acute myocardial infarction, which was completely misinterpreted and, of course, unfortunately had some legal implication after the MR. The curious thing of this case is that we did the diagnosis of acute myocardial infarction from magnetic resonance, and patient did an inverted diagnostic pathway. So I think this was my last case. We are running a bit out of time. So just to show you the differential diagnosis between acute myocardial infarction and myocarditis, which is very straightforward with MR. We mentioned the wavefront ischemic model of necrosis, starting usually from the subendocardium. Like in this case, the lady had a subendocardial involvement with edema resembling an acute process. In myocarditis, things are completely different. The lesion and the enhancement is subepicardial with possible but extremely rare subendocardial involvement. So I think this was my last case. We thank you very much for your attention, and we hope we gave you some good pearls and brought some of our experience. Thank you.